PVP, pedal edema or peripheral edema, all would be present. Again, diagnosis through chest X-ray, echocardiogram, ultrasound. We have got markers now, and they will teach the diagnosis, and they will be treated accordingly. Well, we won't go into the details, but sometimes they require ventilatory support, NIV, or invasive ventilation. Pneumothorax, commonly acute, typically pleuritic chest pains, actually very acute presentation usually. Sometimes it may be subacute, but then usually very acute. The patient suddenly becomes very bad. And you get clinical signs that sudden increased resonance in percussion and less excursion on the site where the pneumothorax is. Chest X-ray, ultrasound, computerized tomography, all make pick up. Possibly ultrasound and computerized tomography are very good in picking up pneumothorax. And then treatment, you know, if it's a tension pneumothorax, you have to immediately drain. You can do a broad intercostal drain, a large bore intercostal drain or a pigtail. Now latest trial says that both are effective, and you can use either with a water seal, and that should be the general principle of therapy. Pulmonary embolism, commonly acute. Sometimes there may be chronic pulmonary embolism, which basically behave as a chronic hypoxemic disease and picked up suddenly that the patient has got multiple pulmonary emboli. But commonly it is acute, sometimes with hemodynamic compromise. They may have pleuritic chest pain, tachycardia, tachypnea, and in big pulmonary embolism, there might be circulatory collapse. Right now, the gold standard is pulmonary CTPA, that is the computerized pulmonary angiogram. And you can get a good idea if it is a reasonably large pulmonary embolus through echo by getting the features of right ventricular strain. And usually the treatment is anticoagulation by heparin or analogs or oral anticoagulants. Nowadays, they have newer oral anticoagulants have been suggested in pulmonary embolism, and if the patient has got a hemodynamic compromise or a signs of RV failure, you may need to go for a thrombolysis. Pleural effusion, it can be acute or chronic, and diagnosis by chest X-ray, ultrasound, computerized tomography. The features will be depending on the cause of the pleural effusion and the treatment as per the causes. And hemothorax, commonly acute, and almost similar to pleural effusion, and you can treat accordingly. Another question is that the approach standard teaching, our teaching has been that you take the history, you do a clinical examination, you do investigations, you diagnose the patient and start treatment. This is the original, our treatment. But in these acute patients who come with an acute hypoxemia, you will have to modify this. Sometimes detailed history is not possible. First thing is that you will have to fix the physiology. Airway, breathing, respiration, circulation, they have to be taken ABC, they have to be taken care of immediately. Otherwise, the patient will not survive. Sometimes you may have to curtail your examination, history taking, etc., and stabilize the patient initially, whatever it may take, sometimes using over-treatment sometimes, and you stabilize the patient, review the response. If you feel the patient has stabilized, then initially short history, later a detailed history, and then you should come with a preliminary diagnosis and act immediately. Like an acute pulmonary embolism, you cannot wait for a positive, definite clinching diagnosis sometimes, and you need to act immediately with a circulatory collapse, otherwise the patient will not survive. So that you should keep in mind, that always it's not that you are getting a honest, good diagnosis first and then treating. You should sometimes react instantly, almost like a knee-jerk reaction, stabilize the patient, and then sometimes in retrospect you might feel that I have treated the patient for pulmonary embolism, but ultimately it came out to be not a pulmonary embolism. But that's all in the game. I mean, that is accepted. You are trying your best to stabilize the patient. Next question is diagnosing. I won't go into the clinics, but I'll go into the basics of the diagnostic test and imaging. This has become very popular. Nowadays, previously it used to be only with a very conscientious physician used to carry. Now almost all physicians, they carry this, and even the patients, they themselves buy and carry this. And their reports are, my SPO2 is this. So this is, and previously there were bigger machines. Now they have become very portable, cheap, and they can be used in bedside. And these are not very bad. You cannot say these are gold standard, but then these are reasonable. They give you a good idea of what is happening. The advantages are they're cheap and non-invasive, and it's a real time that you can see several times, 1 hour, 2 hours, first hour, second hour, 15 minutes. You can see real time and tell what is it. And it might be, as it is measuring the thing peripherally, it might be a better measure of tissue oxygenation. It might be better than even a blood gas that you might be, this might be, at times it might be more helpful. Disadvantages, it measures only oxygen saturation. Of course, the pulse rate is there, that's a different issue, but not the PO2, not the PCO2, not the pH, nothing. And it is unreliable when the patient is hypotensive. That's very important, that if you don't get a, what you call is that you can see that, in this here, you can see the pulsations. This is called the pleth, and this is a pulse rate. If the pulse rate does not match the pulse rate of the patient, what you have measured, or if this pleth doesn't come, so then you know it is unreliable. Another point is that if the patient has got pigmentation, particularly female patients having nail polish, it may not measure well. It may give false reports. And third thing is that if the SpO2 is very low, below 80%, this might be not giving you the exact value. So it is showing a SpO2 of 70%, but actually the patient might be having a SpO2 of 50%. It is quite possible. So it is good for when it is just below the normal, but when it is very severe hypoxemia, it will tell you this is hypoxemic, but the value may not be very reliable. And next, of course, we have right now, most of the hospitals, they have right now the blood gas setup for blood gas patient, and you can get the general informations, the pH, the PCO2, the PaO2, the bicarbonate, and what is called the base deficit, and also an SaO2. Mind it, SaO2 and SpO2 are not the same things. What you measure in the peripherally and the saturation calculated in the blood gas are not the same thing. Blood gas SaO2 is actually a calculated value depending on the PaO2 and pH. But SpO2 here, you measure it directly. So it may be slightly different, particularly patients like carbon monoxide poisoning. So you have got these basic reports, and from that you can get a general idea of what is the primary disease of the patient. All the patients are hypoxemic. It can be hypoventilation. I'll just discuss the arterial blood. I don't need to discuss the venous blood. We don't routinely do venous blood unless it's done by mistake. And so I'll just discuss the arterial blood part. And you can see that if it is a hypoventilation, then what happens? The PO2 is low, the PCO2 is high, and if you give supplemental oxygen, at least initially the patient will improve. Oxygenation and improve substantially. Next is low inhaled oxygen. That is, low inhaled oxygen might be because of the environment. If the patient was in a smoking environment after a fire, or it might be high altitude, or it might be that patient has got obstructions here. So all this will cause a low inhaled PO2. So low inhaled PO2, the arterial blood gas, the oxygen will be low. The patient is tachypneic, try to breathe in more oxygen. So the patient will be in respiratory alkalosis and the PCO would be low. And of course, if you give oxygen properly, the patient will instantly improve. Then there is a thing called a right to left shunt, or it can be opening of the physiological shunts. I'll discuss that. So in that case, if it is a shunt, the PO2 is low, PCO2 is normal, and there is no significant improvement when you give oxygen, or mild improvement with oxygenation. So this might be a congenital disease which is causing the right to left shunt, like Eisenmenger syndrome, or it can be even a severe pneumonia which is shunting the blood away. There is a opening up of physiological shunts. This is called the VQ mismatch that has started, and that can cause this sort of thing. Even a pulmonary embolism may cause a shunting. And last is the diffusion defect, where the PO2 is low, PCO2 is normal, but another thing I have not mentioned is the arterial alveolar oxygen differentiation. This remains normal in hyperventilation and in this low environmental oxygen, but this is increased. That is basically, this means that the patient is getting some amount of oxygen, but actually that is not being absorbed by the lung. The alveolar oxygen is good. That means the patient has inhaled enough oxygen, but the arterial oxygenation is not good. That oxygen has not passed on to the blood through the lung. So this will be present in shunts, this high difference of PaO2, A8 minus AO2, and during exercise for diffusion defects. And even diffusion defects will improve with supplemental oxygen. So with these parameters in your mind, you can generally come to a diagnosis like hyperventilation would be usually secondary to trauma, where the chest X-ray, one chest is not working properly, or a large pneumothorax which is pressing onto and not letting one lung function, or because of central causes like deep sedation, central CNS diseases, major stroke, brainstem infarcts. All these things will cause the patient to go for a low ventilation. So, and in case of hypoventilation, can also be a feature of basically when the patient has got a severe obstructive airway disease. The patient has got ventilation mechanism intact, but because of the airway problem, not enough air is reaching into the lung. And this inhaled PO2, I have told you the situations, and the shunts, I have told you the situations. And diffusion defects are usually interstitial lung diseases or alveolar diseases. Now you can go for the imaging. Commonest imaging, of course, is chest X-ray. Nowadays, we have got Most of the hospital will have a chest CT, HRCT chest with or without contrast, and a CT pulmonary angiogram in some of the hospitals. Echocardiogram gives you the cardiac idea of the cardiac involvement in case of hypoxemia, and we have got a big wave what is coming is now lung ultrasound. We have started using it, many people have started using it, still it is not a common practice in many hospitals. You need to remind the doctor that whether I can do a lung ultrasound. When done properly with a protocol, it can at times match the efficiency of or the sensitivity of a CT scan with no radiation and with much lesser cost. But you need the expertise, that's very important. Chest X-ray, you can see that there might be a hyperinflated lung like an asthma or a emphysema. Then you can have this lobar syndromes in pneumonia, lobar collapse. Then you can have hilar congestion with hypoxemia, which might be signs of heart failure. So these are, I won't go into the discussion of this thing. This is a whole lecture that what might the X-rays in hypoxemic patient. And next is this is the ultrasound, lung ultrasound. Previously, lung was thought to be filled with air, which is not penetrated by the ultrasound or causes lots of aberrations, and that's why lung was not a place where you could do an ultrasound. Most of the radiologists previously they would be trained without doing any lung ultrasound, but now radiologists, chest physicians, and critical care people they have started recognizing the importance of lung ultrasound, popularized by a Frenchman called Liechtenstein. So this is basically what you call, these are called basically normally you get a thing called A lines. These are parallel lines in the lung which you find when you do a lung ultrasound. But this is what is called B lines. These are vertical lines coming. These lines when more than 3 or 4 in number, they are important to show that there is increased wetness of lung, which can be heart failure, which can be one-sided pneumonia. So all these things will give rise to B lines. This can pick up where the X-ray is not picking up the pneumonia, this can be picking up. There are protocols for lung ultrasound. These are called blue protocol, etc. There are views. I won't discuss them right now. Again, sometimes we may discuss it in a separate lecture. Sorry. And another great example of lung ultrasound is picking up the pneumothorax. Pneumothorax, sometimes X-ray might be difficult, even clinically it might be difficult to pick up a pneumothorax, where you can pick up well with the lung ultrasound. Where you find that basically there are 2 types of lung ultrasounds when you do it in an M mode. M mode, when you do an echocardiogram with a probe. So if you find this is the normal part of the lung, normal M mode view of the lung, where there is this parallel sort of lines peripherally, and more deep it goes, it looks like a speckled appearance. This has been called the seashore sign. These are the waves of the seas, and this is the sand. This is the typical pattern. But when you have a pneumothorax, basically the whole thing becomes something like this. So this has been told a barcode pattern. Something you take on the products, you've got barcodes, and this is a barcode pattern. And this is basically, this is called the, there is a line basically, lung line basically, and you can see that this part is the normal lung and this is the pneumothorax. You can actually quantify the pneumothorax with the lung ultrasound. From here to here, the pneumothorax is there and get an idea. So this is lung ultrasound in pneumothorax. And then you have got echo. Let me see whether it runs or not. Yeah, you can see this is you can just make out this is a very poor left ventricular function. Dilated left ventricle, left atrium, all the 4 chambers are dilated, and you can see the mitral regurgitation as well as the tricuspid regurgitation. So typically, if such a patient comes with hypoxemia, first thing you think that this patient is having a left ventricular failure, a poor ejection fraction. But we know right now that heart failures, all heart failures, they do not come with a poor ejection fraction. At least 50% of the heart failures will have a preserved ejection fraction. So that is just normal ejection fraction does not exclude a heart failure. For that, we have come with a thing called a tissue Doppler. Right now you can have, if the patient is in sinus rhythm, you can put the tissue Doppler. This is the tissue Doppler image, and on that you put the pulse wave Doppler, and you get to this downward waves. And this is called the E prime wave, and this is the A prime wave. This is the E prime wave. This is actually compared with the Doppler generated E wave. This is. So E by E prime is the value. If that value is above 13, you start thinking that the patient might be having pulmonary edema. And if it is very high, 20, 25, you know that definitely the patient is in pulmonary edema. This is an excellent test. I mean, when you are not picking up by other things, you can pick up and show that the patient actually is in heart failure, even with a normal ejection fraction. But the problem, limitation of this test is that it is not very good when the patient is in atrial fibrillation. Some people say don't do, some people say you take an average and try to calculate. Anyway, it loses the sensitivity and specificity when the patient is in atrial fibrillation or having too much of extra beats. In a sinus rhythm, this can be a very good tool. And then this is the typical echocardiogram in a patient of pulmonary embolism, large pulmonary embolism. Normally what happens, this is the left ventricle and this is the right ventricle. Normally the left ventricle is a beautiful round circular structure and the right ventricle is compressed because of the left ventricle and remains a sickle here, thin sickle. But when there is a right ventricular stress, the right ventricle becomes large and it presses the free wall between the right and the left ventricle and it becomes straight. So this looks like a D, capital letter D in English, and this is called the D sign. If you can pick this up, then you know there is a good chance that the patient has got a large pulmonary embolism. So this is again a bedside test and it is an invaluable test in picking up large pulmonary embolism. When the patient is unstable, you cannot shift the patient for CT scan. If you can shift the patient for CT scan, then the patient will be, you can do a thing called a CT pulmonary angio, and this is a CT pulmonary angio with a filling defect. You know that the large artery, there's a large clot sitting on the pulmonary artery, and that is the diagnosis of pulmonary embolism. So this has right now become the gold standard. You do a CT pulmonary angio and pick up, except for very peripheral small emboli, most of the pulmonary embolus would be picked up by CT pulmonary angio. Now, what support do we give? I'm not going to go into the details of respiratory failure, but typical to hypoxemia, what support we can give? We are not discussing the treatment. Treatment, as I've told you, will depend on whether the patient has got heart failure or pneumonia or pulmonary embolism and the very treatment. It is beyond the scope of this lecture. But how do we support the oxygenation, particularly supplementation, how do we give? Of course, we have got nasal cannula, we have got masks, and we can also have things called non-rebreathing masks, called bag masks, that we can have. Now we have got some newer instruments. This is a high-flow nasal cannula oxygen. So this was basically, is fixed to a machine which provides high flow, well humidified and warm oxygen. So these three are important, up to 100% and up to a flow of 60 liters per minute. Why it is necessary above a normal mask? Theoretically speaking, a normal mask or a venturi mask, can deliver up to 100% oxygen. But the problem remains that the flow of the venturi mask is not very high. So it is 4, 5, 6 liters, or maybe maximum you can go up to 10, 12, 15 liters a minute. That is how much you can give. But actually these patients are panting, severely hypoxemic patients, they pant. And their air hunger is more. So what happens, the patient's demand is 25 liters a minute. And you are supplying 15 liters a minute maximum. The patient will pull in air from the sides of the mask because of the panting. So ultimately, though theoretically speaking, venturi mask can give up to 90% oxygen supply, it does not supply that. Its maximum capacity around 50 to 60%. After that, it does not supply oxygen. So this is where this machine can deliver up to 60 liters per minute. That is the maximum, which is a huge. And this patient, there is no this air entrainment. So that is the patients, they have got this advantage. Moreover, they maintain the body temperature, which is comfortable for the patient, and there is less dryness of the airways, and they tolerate this high flow oxygen better, and it is well humidified. With mouth closed, if the patient breathes with the mouth closed, but that is not always possible in a dyspneic patient, but then theoretically if the patient keeps his mouth closed, then it can also generate a positive end expiratory pressure of up to 6 centimeters of water. So that is an added advantage. It has been brought in as a sort of replacement for non-invasive ventilation or BiPAP in hypoxemia. The main advantage is the mouth remains free, the patient can eat, patient can talk, if he tolerates, is comfortable with this. This is not very good, although it has been tried in hypercapnic patients with high carbon dioxide, but it is not very good in hypercapnic patient. And sometimes it may give rise to a false sense of security. The patient is basically oxygen saturation maintaining, but the patient is very tachypnic. Always be careful about a patient who is ventilating at a rate of more than 30 breaths per minute, whatever might be the cause. The patient might be just anxious, but it might be so that the hypoxemia has been corrected, but we have not done a blood gas, the patient has got a shock, metabolic acidosis with the increased base deficit. And this patient suddenly will collapse even elderly patients, just a respiratory rate above 30, 35, we should be very careful, and the patient should not be allowed to breathe without a support at that rate. The uses of high-flow-nasal cannula, it has been used in many situations. Acute hypoxemic respiratory failure, the level of evidence is 2. That is, no large double-blind trials, one single open-level studies, and some smaller RCTs and meta-analysis of RCTs. The advantage is that you need less needs for intubation. Less number of patients need intubations. Comfort point is very important. The patients are usually they're very satisfied with that. There is no difference in length of stay or ultimately no mortality benefit with using NIV over NIV, that is. Post-extubation hypoxemia, random controlled trials, you have no difference in reintubation rates. You can be using it, but then patients who are bad will need reintubation. Pre-intubation oxygenation, if you are using pre-intubation, you need to increase the oxygen. There, it is better than the normal conventional nasal cannula mask oxygens, but possibly NIV is even more better in these patients. Post-cardiac surgery patients, non-inferior to NIV. Acute decompensated heart failure, improved respiratory rate, the patient gets relief, no difference in requirement for NIV, mechanical ventilation or mortality. So the most advantage of this, as we gather, is the comfort, and it can you can avoid using the NIV, that is the best thing. In many patients, it can replace the NIV. Patients who do not intubate orders, of course, you can use this. And next is the NIV. This initially was developed for a small machine to be used at home for patients with sleep apnea. That is how it was promoted. But now it is slowly permeating into the general care, hospital, and the ICUs, particularly the advantages being that you avoid the intubation. We know that intubation makes the patient have a discomfort, the patient cannot speak. The patient has got more chance of infection because we breach the physiological barrier to infections, and the infection goes in through the intubated thing, and you need a very good nursing care, suction with a sterile suction. All these are difficult to maintain. You need a special extubation protocol, and then you need to do tracheostomy in some patients. So it is a cumbersome thing. So replace that, we have started with using NIVs. But remember that our original NIVs, which are smaller with an external supply of oxygen, are not really very good for acute hypoxemic patients in ICU. For nowadays, we are having newer NIVs who have come with blenders. The problem with NIV is that when you give through a side port, that the oxygen is connected to a side port as an external, you cannot predict what amount of oxygen is being given to the patient. You might be giving 12 liters of oxygen, but there is a thing called a Venturi effect. Higher the pressure in the NIV, IPAP in the NIV, less oxygen comes through the side port. So same, say 8 liters of oxygen or maybe 5 liters of oxygen when you are giving with an IPAP of 12 by an EPAP of 5, the oxygenation was possibly going around 40%, but now we have increased the IPAP to 18, and then the oxygen, by itself, the oxygen mixture goes lower. Less oxygen enters through the side port. So that is the bane of these older machines. But now you have got newer high quality machines, which has got, and those NIVs were also not very good when the patients were breathing at a rate of with a minute ventilation of more than 15 liters, and they could not match this respiratory hunger of the patients. If they run for long, 24 hours, they sometimes crashed. So these are the problems of the older machines. But now we have got good machines, which are strong machines, and they have got oxygen blenders. You can actually predict that this percent of oxygen we are giving, 50%, 60%, 70% you can use. And they've got several new modes. Again, we can discuss someday in a different lecture. And they've got new modes which can be actually made to order to suit the needs of the patient. But the problem is that the airways is not protected. Patients who are not, sensorium is not good, this is not a good machine. It needs some amount of patient cooperation. You cannot absolutely sedate the patient or paralyze the patient because you need some amount of respiratory effort and some amount of sense to cough out, so you cannot fully sedate these patients. Next is that patients with injury here, they won't be able to do. Patient in severe shock, it is not a preferred mode. Patient post-cardiac arrest is not a preferred mode. So these are all these places where still it cannot be used. Another point is that when you are using a large number of NIVs in this pandemic, we found there is a thing called a SILI. That is just self-induced lung injury. We know that the volume of air going into the lung, actually if it goes above a certain level, it damages the lung. As long as you are giving, say, about 6 ml per kg of tidal volume, it is fine. You go beyond that, say 12 ml per kg you are giving, and then after 5 hours you can see speckles of small punctate hemorrhages all over the lung. For one day you give that high tidal volume, you see that the whole lung has changed the color, become more darker and become more like it's called, previously we used to call this hepatization of the lung, become a solid tissue like a liver. So that is the problem, that is the problem, that is the volute trauma. And here basically what happens that the patient, you don't have any control over the tidal volume. It depends on the patient's effort. So a patient who is taking a deep breath and he does not know he's harming himself by pulling in a huge volume of air, and this is called this self-induced lung injury, almost if the patient is taking in breath and injuring himself. So this is an issue with, and you get a large number of pneumothorax, not very big number, but then maybe 5% chance of pneumothorax and even pneumomediastinum with this high level of NIV ventilation in hypoxemic patients like in COVID pneumonia. What are the recommendations for NIV in acute hypoxemic respiratory failure? Cardiogenic pulmonary edema, it has been well proven that you can use it in cardiogenic pulmonary edema provided the patient is not in shock or post-cardiac arrest. Hypercapnic respiratory failure, it was very good. All of you must be using it. Patients with high carbon dioxide, actually ventilate and you give oxygen. Oxygenation is taken care of and the carbon dioxide is washed out. Recommendation in transplant and immunosuppressant patients where you don't try to avoid intubation as much as possible. And lung resection surgery, abdominal surgery, there you can use this NIV, provided it is not a upper GI surgery or esophageal surgery where it can injure. Severe community acquired pneumonia, initially it was not a preferred mode, but now after this pandemic we know it can be used quite successfully. ARDS, no recommendation, but we have used in this pandemic quite reasonable amount of success. SARS, severe acute respiratory distress, NIV may be used with great caution. Actually, the need for the NIV came because there was such a huge volume of patients, many of the hospitals did not have so many ventilators. So they had to resort to whatever support they could give, and at that point of time, they started using NIVs and found they're useful up to a level, they're quite useful. And trauma, where there is a refracture, the patient has got a flail chest, there also NIV can be very helpful. Next is the last topic I'd be discussing is basically ARDS, and I'd be discussing, I have not discussed the invasive ventilator here because that's again a full separate lecture. ARDS, all of you know that the definition of ARDS changed from 2012. The previous ARDS definition has changed and now we have got a Berlin definition. And all your PGTs should be knowing this Berlin definition well. There might be questions coming from for Berlin as Berlin definition or several aspects of the Berlin definition. So now the definition is, I'm just reminding you that the lung injury or the features of the lung injury should start within 1 week of known clinical insult.
So now sound
that is, you've got a ARDS is usually secondary to something. You've got a pneumonia or you've got a pancreatitis or you've got a sepsis or you've got a trauma, and the lung injury part should start within 1 week of known clinical insult. Chest imaging, bilateral opacity is consistent with ARDS. Sometimes it can be unilateral, but that's not a common thing. There might be, there should not be such lesions which could explain the hypoxemia, large pleural effusion, and the patient is hypoxemic. Possibly the patient is not in ARDS. Or there is a lower lung collapse, and you know that this is the cause, and that is not an ARDS. So that is you should know. Origin of the edema. Many of these patients, this is basically a pulmonary edema, non-cardiogenic pulmonary edema. So that you should be very careful. There is no pulmonary, this cardiac component into this. That is very important. Previously, they said that you need to do a Swan-Ganz catheter, pulmonary catheter, and see that the capillary wedge pressure is low and exclude pulmonary, cardiogenic pulmonary edema. But now they have become practical. Very few centers and very few people do Swan these days. So you can prove this with any means. You can use Swan, you can use a ultrasound or an echocardiogram. You can use this minimally invasive like PICO, LIDCO you can use, and you show that this is not a cardiogenic pulmonary edema. You need to show that. And then you diagnose the ARDS. Once you have diagnosed, there will be 3 categories of ARDS: mild, moderate, and severe. Previously, the mild was called lung injury, but now this term has been discarded. And now we have got mild, moderate, and severe. So if the measure is basically PO2 by FiO2. How much is the patient's partial oxygen, pressure of oxygen in blood, divided by how much oxygen you are giving to the patient. And previously it used to it had no comments on the PEEP, because PEEP makes a difference, but now we have got a comment on the PEEP. So if it is mild, it is less than 200 PO2 by FiO2, sorry, less than 300 but greater than 200, with a PEEP or CPF of more than 5. If it is moderate, it is 100 to 200, and if it is severe, it is less than 100. So this is the 3 categories of ARDS, because it got some changes, recommendation, the change in the treatment. So you can see this is the milder ARDS, and this is a very severe ARDS. In case it is a mild ARDS, you can give basically non-invasive ventilation. Perhaps you can also give HFNO or an NIV both, and you can even give 5 oxygen. After that, it goes below 250 or 200, you need to ventilate the patient, and you need to use a low tidal volume ventilation. I told you that tidal volume going above 6 ml per kg actually injures the lung in the long run. So you need to be very careful about that, maintain that. And then you need to increase the PEEP. If you are not achieving a satisfactory PO2 for ARDS, our cutoff is 56. We need a PO2 of 56, and we should be able to do that with 60% FiO2. If you need more oxygen, actually this oxygen will harm the lung, so you need to increase the PEEP slowly, so that it keeps the alveoli open, drives the fluid away from the alveoli, and that will increase oxygenation with a lesser amount of FiO2, and you try to keep the FiO2 below 60. So slowly the PEEP will increase as the ARDS becomes more severe. If the patient is very tachypneic and severe ARDS, initially they will also require neuromuscular blockade. If the patient is still not maintained with a high PEEP, then you need to prone the patient. Make the patient prone and ventilate the patient. It has been shown. I mean, beyond the scope of this lecture, what is the physiology. And then HFO is now, right now, high frequency oscillatory ventilation is now, right now, no more used. But then we have got a new machine which is called the ECMO. If it is still, the patient is not maintaining enough oxygenation or getting hypercapnic, then you need to use ECMO. Now we have got that machine and it is being used. Even NIV, I told you in ARDS, initially there was no recommendation, but nowadays there is some, not official, but some suggestion that we can use NIV in ARDS too. Use NIV cautiously and only in an ICU where the facilities for intubation and invasive ventilation are available. So you should not be that should not be the last resort. You should have a standby ventilation. If the patient may fail any time and you need to intubate and ventilate. Don't treat an ARDS patient in an ICU which does not have a ventilator at that point of time. Use NIV as early as possible in the ALI ARDS course, but only in the following carefully selected patients. No severe hypoxemia, not severe hypoxemic. No major organ dysfunction. No hypotension or cardiac dysrhythmias, and a SAP score of less than 34. BiPAP is preferred to CPAP. A critical care ventilator, I've already told you that old-time ventilator, old-time NIVs won't help in this situation. You need a full NIV with all settings and a blender. And the patient's head end to be positioned 45 degrees, and the oronasal mask is preferred nasal mask. In these cases, as you are giving a high EPAP to, you cannot use a nasal mask in this patient. Now, this is a 2000 article. This actually changed our outlook. ARMA protocol, this was called, which actually showed that previously the mortality in ARDS was very high. This actually made the first difference. We started getting hold of the ARDS and treating them. This showed that tidal volumes 4 to 6 ml per kg versus 12 ml per kg. There was an indefinite, after up to 180 days after the treatment, there's definitely a survival advantage. These are the traditional tidal volumes, and these are the lower tidal volumes. So there you can see traditional tidal volumes and lower tidal volumes. There is a definitely proportion of patients surviving. It's better with the lower tidal volumes. That is, it was definitely proven. Next came our prone positioning. This is almost 13 years after the first trial. You can see that previously people had tried. They knew the physiology, that basically the lung is actually compromised in the anterior segment. The heart is pressing on it and eating away a part of the lungs volume. And so when the patient is prone, the major part which is patient is supine, the major part which is function is the anterior part of the chest, which is basically half the lung. And the rest lower part of the lung, it remains collapsed in severe ARDS because of several reasons. But when you make the patient prone, this heart comes to the lower part, this part remains collapsed, but the larger part of the volume of the lung, which is more at the backside, they started opening up, and that creates a big difference. And you can see this is the first trial which has shown that the prone group has got a much better survival, almost 80% survival versus the supine group. So this is the thing when you do, if a patient has got a severe ARDS, you need to prone the patient. All patients should get a trial of prone ventilation. The problem remains that if the patient has got other, it is difficult to do procedures like putting in a central line, arterial line when the patient is prone. You need to actually do them before you prone the patient. If the patient suddenly gets a cardiac arrest, etc., then you may need to again make the patient supine, otherwise it is difficult to give. It can be given, but not a good way to give a CPR in that case. And obese patients, it might be difficult technically to do prone the patient and this thing. Usually when the patient is prone, the average time span is 16 hours. Give prone ventilation, see how the patient is improving, and then again make the patient supine, and again if needed, prone the patient. And last is, of course, this is ECMO. This is our patient. You can see the patient is ventilated, and also there's the machine. You can see the machine. This is the ECMO machine, and this is bypassing the lung. The idea is that I have told you the only problem of, or rather not the only, the major problem of treating ARDS is that balancing the oxygenation and maintaining the carbon dioxide of the patient in one hand and causing minimum lung damage, because these lungs, they become very stiff. Lungs become very stiff, almost like a liver, a solid tissue, and it is very difficult to inflate the lung. And so if you need to really put in the oxygen or drive out the carbon dioxide, you need to ventilate at a very high PEEP, and sometimes you need to also increase the inspiratory pressure limit. With high pressure, the ventilation is putting in that, sometimes requiring high tidal volume, and all this actually damages the lung over days. So one side of the thing is that you are treating the ARDS, and your treatment support is actually damaging the ARDS more. That was the bane of the treatment of ARDS. Now, we have got this, that we can use the ventilation to a minimal level just to keep the lung open, say 200 ml of tidal volume in an adult patient, half what the patient would normally require. And the oxygenation and the carbon dioxide is maintained by the machine directly from the blood. So this is a veno-venous ECMO. There are some other uses of the ECMO too. We discussed that sometimes else. And this was the first trial, the CESAR trial, which shows that the benefit of ECMO. You can see a remarkable benefit of ECMO, patients surviving. Almost 75% of the patients surviving with ECMO, and 50% were not in ECMO in ARDS patients. The problem with this trial was that with that people started prescribing ECMO to all ARDS patients. But the problem of the trial was two. One was that it was a single center trial, and next was that it was sort of not actually a controlled trial. It was basically a series, prospective series. Some patients were sent for ECMO and some patients were sent for normal conventional ventilation. The patients who were sent for conventional ventilator, they were not always sent to the good tertiary care centers. And they were there, many of the patients, they did not follow the basic principles of ARDS management. So possibly the mortality was higher in the control group. So these were the people got the idea that definitely ECMO is good, but how good it is, it was not proven. So now we have got this Julia trial. Next trial, this is a multi-center French trial, and 249 patients of severe ARDS. Here you can see the PaO2, FiO2 is less than 50, and PaCO2 of 60 were randomized to receive ECMO or conventional therapy. 124 received ECMO and 125 conventional therapy. Of course, there was a protocol for changeover. You see the patient is not surviving in conventional therapy, they could switch over to ECMO. And 35 such patients were sent to rescue ECMO. Primary endpoint was 60 days mortality. And you can see even here the ECMO group was better than the control group. The idea after the Julia trial is that basically is slightly different from the CESAR trial. CESAR trial told that all severe ARDS patients should ECMO, but here Julia, after that, bottom line would be that you should try the normal conventional treatment, even with prone ventilation. If you fail with the prone ventilation, then you should go for ECMO. The contraindications to ECMO are that if the patient, you feel the patient has got a non-treatable disease, ultimately the patient is going to die, don't put the patient, it is a hugely expensive, and the time frame, usually patient requiring ECMO will require almost a month or more to get out of the ARDS. So that is very important, and people who are having multi-organ failure, they are also not good for ECMO, particularly severe shock, gone into a full renal shutdown. Not that you cannot do, but the results are not good. People who are elderly also don't do well in ECMO. Usually younger patients, they do well on ECMO. Thank you. I've touched a few points. So if you have got any issues about this point, you can tell me and I can elaborate if you need.
Thank you, sir. In fact, the whole issue is discussed and elaborated at the backdrop of pathophysiology. Since we have faced COVID crisis, ventilation, both NIV and and invasive ventilation was very confusing areas. Now I request the audience, if any issue can be clarified from our guest lecturer, kindly come forward and can put your question. The floor is open.
Yeah, as I've told you that when we prone, the protocol, in the prone ventilation protocol, the thing was done for 16 hours at a stretch. 16 hours of proning, then again supine, and then again 16 hours if needed. That is how the protocol was. But when you actually practically do it, not that all patients, they will improve in 16 hours. Definitely, once you make the patient prone, you will see the PO2 improve, the carbon dioxide come down, these things will happen in most of the patient, except for an unlucky few. But if you feel that it is working, we have continued the prone for more than 24 hours sometimes. The patient has stabilized a bit, then made the patient supine, watch for few hours. If the patient was not okay, then made the patient prone again. That we have done.
And next session is already on the web. So I request the guest lecturer to take his seat and please come here, sir. Please come here. And we will go for a small felicitation program, followed by our next session will be started.
Thank you, sir, for your valuable share of words. Sir, can you please come up on the stage for your felicitation? So, our next speaker will be Dr. Devabroto Vera, who will join us on the online session, and the topic will be PG ECG session. Thank you.